anybody hear me? Can we turn this up? Hello, good morning. There it is. All right, so welcome. This is kind of a special day for us. This is our 25th Cardiovascular Symposium and Wellness. And we're happy to have everybody here. We'll eventually get some tallies on how many people we have, but I think between the people here and the online, we're going to have quite a crowd. So as usual, first thing I want to do is thank our sponsors that help make this a basically free event for everybody, which I think they all appreciate. So I will name them off, and then we can give them some gratitude. So Boehringer Ingelheim, Janssen, Chiesi USA, Medtronic, Novartis, Mercy, Enliam, Pfizer, AstraZeneca, Atracure, Novo Nordisk, Boston Scientific, and the American Heart Association, aside from Monument itself, and thank you for their help. Please remember to go talk to them throughout all of our breaks and lunch, as that will make them feel good and make sure that they help us again next year. If without that, they might not. Also, it's a special day because we linked up with the American College of Cardiology and did some advertising through them. So we have more viewers who are not from our local area but wanted to take advantage of this level of education. So welcome to all of those folks who are probably seeing me through that camera over there. So thanks for their attendance. We're also going to kick this off with a little bit of review of the agenda. So you guys have it there. Actually, we only changed it, I think, 3 times in the last week. So it should be what it is there. One thing that's not on there is at 5:30, we're having a little hors d'oeuvre hour and gathering, after which I'm actually going to do a little presentation on what the American College of Cardiology has been up to. I just got back from Washington, D.C. Last weekend, and we had to do some legislative action. So all of that to try to improve healthcare and maybe get you guys a little more money over time. So that's always a good thing. As the saying goes, no money, no mission. So beyond that, what am I missing for housekeeping, Drew?
Phones.
Phones. Please silence your phones. So I'm Dr. Alex Schabauer. If I didn't do that, this is Dr. Drew Purdy. And since it's our 25th, we're actually going to kick off with some slides that will review a little bit of our history of doing this. And I can see them here. And I think we wanted to start off with, I think you were going to take the first cue.
Okay. So we've been doing this symposium, like we talked, for 25 years. Originally, like you'll see, it actually was something that cost people money to attend. And it used to be a 2-day affair, and it used to be quite a presentation. It kind of dwindled a little bit and then reconstituted here in the last 10 or 15 years. And so we've been really pleased. These just shows you not only how the marketing has changed, but also a few things about the symposium itself and all the different things that we've seen over time. So this is what we learned 20 years ago, our agenda for our Arrhythmia Symposium. And then here you can see they're charging $100 for 2 days, and then this is what you got to see in 2007. And then charges dropped, and then eventually, since 2012, with our sponsors and with Monument, we've been able to provide all the education free to everybody that's here. So I think that's really a really important thing that everybody has put together to contribute. So
some of the same topics I think have come up over the years. We usually do surveys at the end of these, so make sure you fill those out, because you'd be surprised the number of times people will either ask for something either completely unrelated to cardiology, or the same topic will come up. They want to hear more about stroke. They want to hear more about lipid. Part of the reason this is called a wellness symposium as well is we always got very positive feedback on doing wellness discussions, and we're going to do that again today. The expansion of our group, there's some old pictures. That's fun.
Yeah.
So
a few of our presenters over time.
So that's Tuma and Bhaskar and Hatton Ellis, and Teixeira was always a favorite. And Paulette's down there for doing the intro. I think I'm on one of those or so. And there's Barbera. Teixeira always likes to walk around the stage, so...
He's hard to get a picture of.
He's hard to get a picture of, exactly. Is that Fozzie in the middle now? Amir?
Yep.
Yeah. Those are good pictures. Believe it or not, these group photos were largely photoshopped. We weren't found in the same room at the same time on any of those occasions.
But shows how things have changed over time, and I think this is kind of the older generation of people who helped start this event and started the cardiovascular program here. And I think John Telcott later is going to talk about the next generation of people that are coming and going to be involved in this. One thing, too, that we'll chat about is just in terms of growth. I mean, because I don't remember how many cardiologists there were in 25 years ago, but probably 6.
Yeah, we were down to 6 and 5 before Walter got here. We were at 8 when I got here in 1996. So the other thing that's grown quite a bit, Roger was here when I got here as an APP, and then we got Joanne Detweiler, and she moved on to greener pastures, and then Diane got here, and then Evelyn got here, and then Lizanne got here, and now we're up to, what did you say?
Well, right now we have presently 26 providers, APPs, and 4 more are on their way. So we've gone from a few to 30.
Yeah.
And likewise, cardiology numbers have gone up significantly. Dr. Teixeira was our lone EP physician for many years, and now we have Dr. Barbera and Levine here. Likewise, when we started this 25 years ago, our entire research department was sitting in that chair right there, named Roger Durad. And now there's 20 employees that are involved in research, so that's grown tremendously over the last 25 years. So all of these things have just been, a tremendous boost to the region, and this has been great to have been part of it all.
The concept of team-based care is never a secret. Oh, those are great.
I'm going to say these. who put all these old people in here?
But the team-based care has really come to fruition. As I said, I was just in D.C., and everybody is working with the same concepts. You can't do anything without a well-trained and well-experienced team, which is part of the reason we do this every year, is to get our team up and running and as current as we can get them.
I think just looking at this slide and looking at EP and pacing, I mean, the dramatic expansion and growth of the EP program, and I remember when Dr. Teixeira had gone away and learned at South Carolina and other places how to do different types of ablation and AFib ablations, and now we're doing 700 a year. I mean, it's just grown like tremendous amount. So
yeah,
a lot of things happen in 25 years.
Remember how the cardiovascular surgery rates went down, right, when we got really good at stenting, but we all knew eventually those stents would go bad, and then the bypass rates would go back up.
Come back up again until we got drug-eluting stents, and now we have drug-eluting balloons. So
right.
We'll see less of stenting perhaps down the road.
Hopefully.
But this just historically kind of tells you a little bit about how treatment has changed and what we've had available to us, and not just stents in general, but the quality and types of stents. Our ability to get stents in locations we never could before has just been a dramatic improvement over time.
I remember how stiff those things were when you first started doing that.
I remember, and Sam remembers as well, we used to crimp our own stents on the balloons.
Yeah.
Sometimes they came off.
Sometimes they came off.
There's
a few
good.
In some arms here and there.
Yeah. Sometimes they came off, so it was not good. But yeah, we started a long time back when. So a lot of things have changed, and all for the better.
You got to go back a slide. I don't think either one of us was around in the 1950s, but maybe were you practicing in the 1950s?
I was born in the 1950s. But I remember going to not Medtronic, what's the one in Minneapolis, the big pacer company?
I thought that was Medtronic. Didn't they have the first pacemaker?
Yeah, it was Medtronic. Yeah. Going to the Medtronic Museum and seeing the first pacemaker.
Yep.
And this guy was walking down the hallway with one of those little radio flyer wagons pulling his pacemaker behind him. And literally, it was that large, and it had to sit in the thing. And he was like pulling it along with these driver tubes going in and attached to his heart. Wasn't much of a life, but it was a beginning.
Right.
And now we have leadless pacemakers, and then soon to come there'll be leadless AV synchronous
Right.
pacemakers, and then probably in the future bi-V leadless pacemakers.
Sure.
So be a lot of things coming down the road. Everything's getting miniaturized over time.
It's hard to imagine what'll happen in another 25 years.
I won't be here.
You might be the patient. As would I.
Perhaps.
Yeah. What else you got in that file of pictures?
That's it. That's the last one.
All right. Well,
All right.
that was our little walk through memory lane. And we thought it'd be fun to go through that a little bit since some of the people in the room maybe weren't alive in the 1950s. So, all right. Thank you, Drew.
Yep.
Yay. All right, now we're going to move on to our regular scheduled programming. The first thing we're going to do is have a presentation by Dr. Luis Hernandez on optimizing patient care and advanced heart failure guidance for timely referral and evaluation for heart transplant and LVAD. Some of these heart failure topics are going to come up a couple of times today. Luis is a valued member of our group. He came on as just after he finished his general cardiology fellowship, and he kept telling us that he loved heart failure, and he loved heart failure, and he loved heart failure. And pretty soon he got a license plate on his car that says, "I love HF." So we started to believe him. And with that, we were able to help him go off to an additional fellowship last year in Cleveland Clinic. So he's originally from Honduras, and he graduated from the Universidad Nacional Autómata de Honduras, and then he went to, say that 3 times fast. And then he did internal medicine at St. Joseph's Hospital in Chicago, where he learned that he actually liked colder weather more than hot weather, which is hard. You know, normally we have to tell people, don't worry, it's not that cold here. He was like, I'm looking for the cold. Then he did Cleveland Clinic, Florida for his cardiology, and followed up with, as I just mentioned, Cleveland Clinic in Cleveland to do an advanced heart failure fellowship. So with that, let's welcome Dr. Hernandez. Do you have your own mic on?
I think so, yes.
Okay.
Just to answer your question, I wasn't born in 1950.
No.
Okay. I think you probably were.
No.
Good morning, everyone. Thank you for being this early here to listen to me talk today about the guidance for timely referral and evaluation for advanced heart failure. The reason I decided to touch this topic is because we have guidelines done since I don't even know when. And we have medications and guidelines mentioned. And I see patients every day and still not in the right medication. So I don't know what we can do different to change this. And that's the main reason I decided to touch this subject today. So first slide, no disclosure. I have a lot of slides. If I start talking very fast, let me know. I get excited. And those who knows me know how excited I get. So just let me know. So our objectives for today basically is understanding the guideline-directed medical therapy, enhancing what is the timely referral for these patients to be evaluated, and just to increase awareness of understanding what is an LVAD, how do they work, and basically know that we can make people's life better. So a little bit of facts about heart failure. Basically, we know that we have about 6.2 million of adults in the United States that has heart failure. In 2018, basically heart failure was mentioned in 800 deaths in the certificate. So meaning that almost 13.4% of these patients die from heart failure. And the cost that we got for the nation is an average of 30.7 billion in 2012. And this includes patients' health services, basically medicine for heart failure, and at the same time, people that is not able to work. So coming back to the guidelines, right? I find a slide that is easy, has everything in it. Everything green means a level 1 evidence. So we know our patients should be in quadruple therapy. And again, guidelines have been there for years. And till 2023, our patients are not in this right medicine. So we know the beta blockers, SGLT2s, MRAs, and we have ACE, ARBs, and ARNIs are number one or class one. So those patients should be in those 4 medicines. And then we have other ones, the ones in yellow down there, which is basically based on the phenotype of the patient, okay? But if we can put our patients in those 4 medicines, we can at least try to, as Dr. Hernandez will talk about preventive medicine today, obviously when we start putting patients in medications, not prevention, but if we can prevent them to progress to advanced heart failure, that would be ideal. This is what we are doing in the hospital right now. So we try to initiate all the 4 pillars in the hospital while the patients are already admitted. Why do we want to do this? Because we know already that these patients are more likely to be treated, more likely to be adherent to the medications. Easy because they leave the hospital on those medications. It's easy to adhere to that new regimen with 4 new pills. It's easy, and they feel better. They have less hospitalizations, so the heart can improve very fast. So, straight point is important that patients are in quadruple therapy. So what is the term advanced heart failure? And I can tell you, it's very complicated. And that's the reason people don't know what is advanced heart failure. Because even for me, I'm going to explain in a second how hard it is to define it. So basically, it's a clinical syndrome characterized by persistent or progressive symptoms and LV dysfunction despite patient being in all this medical therapy, right? So what is the problem with the definition of advanced heart failure? We have 3 biggest societies: American Heart Association, European Society of Cardiology, and we have the Heart Failure Society of America, which is our main pillar for heart failure. And all of them, as you see, all of them have a totally different definition. The only thing they actually agree to is together is the middle part: severe symptoms, unoptimal medical therapy, recurrent hospitalization, severe functional status. But all of them have different definitions. So it's very hard to put all of them together. So even us as a team, we don't know how to really define it, right? So again, the basic thing is patients will have heart class association 3 to 4, severe symptoms, on medical therapy, recurrent hospitalizations, an ability to be in those medicines, start having end organ dysfunction, persistent hyponatremia, and again, different things from different societies, okay? So it's hard to really understand, it's hard to define. So when we talk about advanced heart failure, what can we offer to these patients? We only have 3 things we can offer. Or either we can offer a heart transplant, or either we can offer a heart pump, or either we can do palliative, right? What nobody likes to talk about palliative, but it's something that we can offer. It's okay if the patient doesn't want to do anything, okay? We cannot save everyone, and not everyone wants to go to this, having a transplant, having an LVAD, but it's a big deal, okay? It's not just a big deal for the patient, it's a big deal for the family and everyone around them too, okay? So it's okay if patient says, I don't want to do this, and that's okay. We're here to help them and to guide them. What I want to bring up today is 62,000 patients with heart failure are appropriate for LVAD therapy. And this is in all US, right? But as you can see in my last circle, I don't know if you can see it because I know the number, we only implant 4,000 to 5,000 LVADs a year. So we have a gap of 58,000 patients who are candidates for this therapy that will make them feel better, and we're still not getting them to the right, person to see them. So it's important to remember that, advanced heart failure therapy, patients had options. And again, they can decide if they don't want it, but there's other options for these patients to feel better. When we come to heart transplant, because my job today in this lecture is to convince you how much advanced heart failure can do for the patients, right? So let's talk about heart transplant. How much people can live in heart transplant. And this is data from the ISHLT, from the Lung Transplant Society, basically from 2009. And you can see here, let me see if this works. You can see here, so basically survival, right? Obviously, the older you are, the higher risk of death compared to younger patients. But you can see that the survival of 5 years is around 78 to 82%, okay? So 5 years later, this patient who gets transplant will be alive 5 years later, right? Since we don't have transplant here in Rapid and we don't have LVAD, but we're gonna have in the future, let me convince you about an LVAD, okay? Let me tell you about how LVAD has changed throughout the years. So I think this is when Dr. Schabauer was born, because I didn't have it, okay? So I don't even know what is this. So this is the HeartMate X. That's the first LVAD that we have. And you see how with time, this LVAD has been becoming very smaller and smaller and smaller. So then we have the HeartMate 2 in 2008. which is the axial flow. And then now we have our new one, which is a HeartMate 3, which is a centrifugal pump and very small compared to the old pump. So everything, as you can see, has been reduced, smaller pumps, smaller everything, but unfortunately we still have to use batteries outside. So what is the data behind the LVAD, right? Why do I'm telling you the LVAD is so good? So everything started with the Momentum trials. So the Momentum trial, which was published in 2018, basically they start these patients who were in HeartMate, they put patients in HeartMate 2 and HeartMate 3, and they compared them. And 2 years later, we were able to notice that patients who were in HeartMate 3, the blue line, actually did better than HeartMate 2. And this was in 2018 when the FDA said, well, it looks like the HeartMate 3 is better. We're gonna give you permission to start implanting HeartMate 3 with the caveat that for the next 3 years, you need to record and document all the complications of this LVAD. And that's how the Momentum trial came, the Momentum 2. So this is the same trial but extended for 5 years data. And now we have the data for 5 years. And you still can see that patients who were in HeartMate 3 actually had a better survival than patients that were in HeartMate 2. Okay? So now the only available pump that we have in the country is a HeartMate 3. So we were able to prove that there was less risk of bleeding, less risk of stroke, less risk of complications, and everything was less risky. So basically the HeartMate 3 was better than the HeartMate 2, okay? And this is the reason it's the only one. We used to have another pump, which was removed from the market because it can cause strokes. You don't want to have strokes, right? And it's actually, the change between the hardware and the HeartMate is like almost like 15%. So you have a 20% risk of stroke versus a 5% risk of stroke. So this is a slide that compares LVADs with heart transplant. And what I want to point here is, again, this is when Dr. Schabauer was born. But here you can see here the HeartMate 3 versus transplant. You can see that the 5 years, 5 years after implantation or after transplantation, the survival is almost similar. 84%, 82%. So this is, I believe that in a couple years, whenever we can finally do an LVAD that will be fully implantable, probably we're gonna just leave the heart transplantation for those patients who are not a candidate for an LVAD. Because eventually we know they have similar, mortality benefits. So why go to having someone in immunosuppression that will cause other problems when you can just be concomitant, okay? So one, I think that will be, as Dr. Schabauer was saying, 25 years from now, I will probably still be alive, but, but this is probably what is coming. So the last thing I'm gonna focus on this, and this is just for you to know how much LVADs have changed people's life. And because we know more, right? We know now we have specialists just in this, is I want you to focus on this last portion of the slides. We know now that survival 5 years is good, right? We say around 82%. We know already that this patient have a better quality of life. We know that once you get an LVAD and you get, you heal and everything, you go from a class 4, class 3 to a class 1 and class 2. So patients can do better, okay? So always remember, this is an option for your patients. What about inotropes? Inotropes is when we use them for palliative, right? If the patient doesn't want to do anything, we can do inotropic support, which is okay? If the patient does what they want, it's okay. But you need to keep in mind that we know already that the survival almost 1 year is between 50 to 70%, meaning that 50 to 70% of those patients in inotrope will die, okay? And 2 years later, almost 90% of those patients will die. So being in inotropes can give them probably a better quality of life, less hospital time, but they will probably die sooner. And obviously there are other complications, right? You can have death, you can have centralized infections, you can have ICD shocks, which is still debatable, but there's a lot of things you can have. So there's 4 questions that I want you to ask yourself when you think about a patient. The first question is, does the patient has or is approaching advanced heart failure stage, right? And again, this is a hard thing to define. So what I consider advanced heart failure, basically progressive renal failure, escalating diuretics, needing patients who are CRT are not responding, EF persistently less than 25%, more than 2 hospitalizations, recurrent shocks, persistent heart failure symptoms, cardiac cachexia, and any high-risk profile, which means elevated BNP, hyponatremia. How do we know that these are high risk? My next slide is probably very big, but I'm not gonna talk about that, I'm just gonna mention something. all those high-risk profiles come from this called I need help. And I'm gonna explain you how we got to this information, right? So I need help basically means the patients are inotropes, they have persistent symptoms, elevated BNP, and organ dysfunction, low ejection fractions, defibrillator shock, several hospitalizations, edema, low blood pressure, and obviously not responding to medication. So to get to this, we went to all these studies, and this is a guidance for you guys when to send these patients to us. So what is the data behind these studies, right? So the data behind these studies is very simple. If your EF is less than 20%, or if your EF is low, so the lower your EF, you have higher mortality, right? Then the other data we have is, if your creatinine is worse, higher mortality. If your BMI is low, meaning that you are, cachectic, higher mortality. If your blood pressure is low, if the EF is low, which is the dark one here, the black one, if your EF is low and your systolic blood pressure is low, higher mortality. If, obviously, if you're older, your blood pressure is low, you have higher mortality too. Then what else do we know about hospitalizations? We know that the more hospitalizations you have, the higher the mortality, right? The lower survival. And what is important about hospitalizations is, and that's why we focus on more than one, more than two, is they add on one after another one. It's not because I got one 6 months ago and one yesterday, it doesn't count. No, the more hospitalization you have, the worse the prognosis. So it's like addition, right? We know already almost 40% chances of dying in the next 12 months if you have 2 hospitalizations for heart failure in a year. We know already that if your blood pressure is lower, so the lower the blood pressure, so this numbers down are the lower blood pressure, lower systolic, lower diastolic, higher mortality in heart failure. What other clues we can see in the echo, right? When you guys get an echo, receive the report, what things you can look for it? If the LV is dilated, if the patient had severe secondary MR, if the patient had severe pulmonary hypertension, if the patient had a restricted cardiomyopathy, if the patient has RB dysfunction. What about metabolic stress test? We don't have this in rapid yet, but we're gonna have one, right, John? Where is John? Oh, yeah, okay. So we're gonna have one here soon, right? So this can help us to stratify these patients, and basically a peak VO2 less than 14 on non-beta blockers and a peak VO2 less than 12 in beta blockers is a kind of like a reason to send them for advanced therapies. What about hemodynamics? And this is the most important point that I want to prove, because this is so simple to do, right? What is the number that I want you to remember today, or what is the name of the most important number that you need to remember? And I put it in red there. Can you guys see it? Right, okay, it's in red, good. So when we see a low cardiac output or a low cardiac index, that's the number that you need to remember. That's the first number that if you see it low, refer it to heart failure. We need to see what we can do for these patients, okay? That's the main important number. Why is the most important number? Because as soon as we start going from normal to a low cardiac output state and an impaired cardiac output with exercise, that's when deaths come in, okay? So as soon as we notice a low cardiac output, low cardiac index, that should be your first thought process about sending these patients for advanced therapies. Why do we know that? Why do I'm focusing on the cardiac index and output? It's because we have studies that we show that if you have a lower cardiac output, you have a lower mortality compared to people who had a normal cardiac output. If you have a normal cardiac output with low VO2, which we talk about the VO2, right? You have a higher mortality. If you have a combination of both, low cardiac output, low VO2, your mortality is even worse, okay? So remember, low cardiac output, low peak VO2. What about scores? We can use scores to define heart failure. We have a bunch of scores there, but I only tell people scores are there to help us and guide us, but really doesn't tell the real story. But if you by any chance decide to do a score, you can use the Seattle model score, and if the survival is less than 80, this can tell you should send these patients to refer them to heart failure. This is how the heart failure looks, the scores looks. This is the MAGIC score, and this is the Seattle. And what I like from the Seattle is you see here in the upper portion here, you can actually get a prediction of 1, 2, and 5 years mortality, and you can actually do a prediction how much you're going to improve if you do some modifications. So if you add the modifiers here, or whatever your interventions you're going to do, you have an idea what is going to happen with this patient. We have LVAD scores, which this was done in Cleveland Clinic by Dr. Estep, and basically if you do the, it's called the HM3RS, so the HeartMate 3 score, risk score. And if you have if you can see here, if you have a low number in this score, which is very complicated to do, you see how many things you need to fill up here, higher than average survival. If you have a higher score, then you have a lower than average survival. And this is we use it, I used to use it in fellowship when you were older than 70, because that's when it can get a little bit more complicated. Then the second question you need to ask yourself is, if the patient has advanced heart failure, could they benefit from having their care at an advanced heart failure and transplant center versus their current site, okay? That's the question, Lord. So what do you guys think? Yes, I like it. So why, right? Why yes? Because these are the benefits that you can get from an advanced heart failure center, right? They have clinical studies. They know how to optimize this DDMT. You know, they can actually do the full evaluation if this patient is a candidate. But let me tell you, we can do everything here now, okay? So you don't have to refer them. We can actually have a connection with University of Minnesota now that we see these patients. There's certain studies that we can do here. And then the patient will be seen virtually first. So they agree with our assessment before we can actually send them to Minnesota. So we're actually making this easier for the patients, okay? But always sending these patients to an advanced therapy center is the right answer. What can you do for us? What can you do for us before we decided to see these patients, or while they're waiting to be seen by us, or while they're waiting to be seen at Minnesota, for example, right? Or wherever they decide to go. So what can you do? Make sure that you evaluate and treat reversible causes, attempt to initiate GDMT, those 4 pillars that I mentioned. But again, for an example is the cubitril and valsartan has been in the market. I looked into it 2015, and I'm still 2023, my patients are in ACE or NARBs, okay? So my point is we should be better on this, right? Device optimization, manage all the non-cardiac comorbidities like diabetes, hypertension, things that you guys can do for us. Educate this patient. And what is important, and people don't think about this, because I feel like a social worker every day, and glad we have social workers, is adequate support. I think this is one of the most important things or my biggest challenge every day in my work, trying to sort out who do they live with, who is the family, who can help you if you need an LVAD, who can help you if you need a transplant. So trying to sort out that social support is important for us. Third question is, what is the optimal timing for referral for advanced therapies? And the answer to this is, I don't know the answer to this, right? Because every patient is different. I already give you a lot of clues that you can use. I gave you an example of what things, but I always tell people, when you're in doubt, just refer these patients, right? Because if you don't know, do it for your patient. It's about patient care, right? If you don't know what you're doing, send it to the person who can do it, or the group that can do it, and go from there. There's nothing wrong in sending the patient earlier. We will probably say, I think you're not sick enough. We're gonna do this. We can actually optimize these patients and go from there. So as Dr. Hernandez will talk about prevention, that's a way to prevent them to going from stage C to a stage D, right? We're trying to prevent this patient to go into heart transplant and an LVAD, if we can do it. So what is the right timing? Again, it's very hard, right? But an idea for you is we will ideally prefer the patients to come to us when they're in this golden window, right? When they're having class 3 symptoms, where they're having inability to tolerate GDMT, the normal medicines we use, when we have frequent hospitalizations, when they have ICD shocks, or when they're having worsening renal function. But we are okay with getting early referrals, especially in those high-risk patients, right? What do I mean by high risk? What I mentioned at the beginning, right? This patient you are going up in the diuretics, having persistent symptoms, or again, if you don't know what to do, just send it to us. We will figure it out for you. Why is it important? Because when you send it, most of the time when you send us something, we're here. Patients are in end organ dysfunction. They have severe malnourishment. There's nothing we can do, and even with all the therapy, they don't recover very quickly, right? And basically this ended in death, and that's what we want to prevent. This is the last question. Any contraindications for advanced heart failure therapy? So this is the last question you need to ask, right? If this patient is a candidate, if this patient is not a candidate, right? And I said heart transplant there because the main struggle is heart transplant. LVAD, almost everyone has no contraindication to get an LVAD. Very minimal or rare occasions you cannot get an LVAD. So for heart transplant, it's the main limit. So this is the first thing, age, okay? We're gonna go to guidelines. What does guidelines said? So this is what you need to think when you're thinking about, should I refer this patient? And again, if you don't know, just refer the patient, right? So age, 70. Based on guidelines, your cutoff age for transplant in every country, in every program is different, is 70 years old, okay? So if you're less than 70, okay, so 69 and a half, you know, or Dr. Chabauer age, you know, or Dr. Purdy, 1950, then you still can qualify for a transplant, right? So that's important to remember. So not because you're 59, you're old, okay? Because that's not old. In heart transplant world, it's 70. Saying that, I had 72 years old who got transplanted during my fellowship, but you have to be a pristine 72, okay? Which is not very common, but you still can twitch the rules a little bit. For LVAD, there's no rule of age, okay? But I tend to tell people, if you're less than 80, I'm okay with an LVAD. When you're more than 80, it's a little bit more complicated, okay? So for LVAD, 70 to 80 is the time that you can use LVAD. And you can use LVAD at any time. Again, very rare occasions you cannot. Nutrition and obesity. So the most extreme in life are bad, right? We do know by studies already that if you are malnourished, you have a worse prognosis. So if you are have a low BMI or cardiac cachexia, it's worse. If you're obesity, that's worse too. Where does obesity comes into play? The main issue with obesity is for transplantation. Again, all this is our contraindications for transplant, right? If your BMI is more than 35, like Cleveland Clinic is 35, Minnesota is 38. So every program is different. You have higher risk of mortality. So we always try to if the BMI is high, we can put an LVAD. We help them to kind of lose weight a little bit, and then we can make them candidates for transplant. So being obese is not the end of the world. Being skinny and malnourished, that's harder because it's hard to get back again in track. But if they are higher in weight, we can always place an LVAD and try to help them lose weight. What I always tell people, and people don't know this, is once you get an LVAD, you actually gain weight. And we'll say, how is that possible? Well, patients feel better. They go from a New York Class Association 4 to 1. So now they can eat better. They feel hungry. You know, they don't feel bloated anymore. So they have to be careful with weight when you put an LVAD with the intention of bridging them for transplantation. What about being frail, right? We know all this. If heart failure patients are frail, the higher the frailty you have, the worse mortality and poor outcomes. What about pulmonary hypertension, right? Pulmonary hypertension is a contraindication basically for heart transplant, okay? It's never a contraindication for LVAD. And the reason it's a contraindication for heart transplantation is because the new heart will struggle. The RB will struggle with the high pressures, right? You're implanting a new perfect heart in someone who had the pulmonary vascular resistance very high. The vasculature of the lungs is actually making the pressures high, so the new heart will struggle. But with an LVAD, and again, that's the only realistic short term you have is when you have high PA pressures, we put an LVAD, and voila, 6 months later, they're a candidate for transplant because the pressures went down again, they remodel again, and you can be a candidate for transplantation again. Unless this is severe PH, right? That's a different story, but I'm saying PH secondary to a pump. What about RB dysfunction? We have a lot of things in echo that we can do, and none of them are really good, to be honest. So we see them, we have an idea. The only measurement that we know that can help us predict it is the PAPI, which is basically, we do it with a right heart cath. We measure the PA systolic minus diastolic divided by CBP, and that's, if it's less than 2, you have high risk of the RB failing. What about malignancy? Having cancer 10 years ago is not a contraindication for transplant, okay? Because a lot of people say, oh, you had cancer 10 years ago, you are not a candidate. That's not true. If you have a cancer in the last 5 years, or you have an active cancer, that's most likely the reason you're not a candidate for transplant. But if you had a cancer 10 years ago, it's cured, no metastasis, and oncology is okay to clear you, be my guest, you're gonna be a candidate for transplant, okay? Again, active cancers, you're not a candidate. If this is all, you can be a candidate, okay? Why this is important? Because when people use immunosuppression, all this medicine for transplant will make the cancer come back, okay? Diabetes, so that's where, again, PCP come into play, right? A1C of 7.5. So if you have an A1C more than 7.5, that's a relative contraindication, and every program is different. I can tell you where I was trained, if your A1C was 8, you cannot get a transplant, okay? We were very rigid about that. UM is a little bit more open to it, depending on the number, based on, I spend some time with them. So one thing to remember is after LVAD, because patient is able to do more physical activity, actually we know that the A1C tends to go down, okay? So sometimes you have to do an LVAD in the middle, put an LVAD and get them through. Renal dysfunction, this is the one that I don't like. So if you have already a kidney problem, if you had already impaired renal function, obviously that's worse prognosis, right? But the part that you need to know is if you have a GFR between 30 to 60, it's not a contraindication for transplant. Now we know that if your GFR is less than 30, it should be better. But what about dialysis patients, right? Are you a candidate? So I tell people this. It's a question mark because every program is different. We don't have dialysis center that has LVAD, able to do dialysis on LVAD patients. So the answer should be, you should not be offering an LVAD if the patient is high risk of dialysis, okay? Because you're gonna have the patients, and I experienced this as a fellow. We were gonna have patients there for 9 months, waiting to find a place to send them home. If you had PAD or peripheral vascular disease, or you have strokes or a history of, carotid disease, you should not be a candidate for transplant. If you have hepatic dysfunction, what you need to know is we check everyone for liver. We even do biopsies. If that's the case, everything is clean, you're a candidate. If you're not, if you have chronic liver disease with high bilirubin and a MEL score more than 17, that's a contraindication. If you have bilirubin between 1 to 3 and biopsy showing no fibrosis, you still can do it. If you have acute liver, because they come with congestion, if you decongest them and they get better, they can be a candidate. Infections, active infections is not an issue, specifically for LVAD, but obviously we treat infections, and once they're clear, we can list them for transplant. What about HIV patients? Believe it or not, having HIV is not a big deal anymore. Patients with HIV do the same way a patient without HIV, okay? And now with hepatitis C treatment, hepatitis C is not a big deal anymore neither. If you have COPD or any pulmonary disease, you need to know that you always do PFTs in all these patients. If you have any of those, you won't have a transplant. In that case, you probably need a heart and a lung transplant, which is more complicated. 2 organs is harder than 1. What about surgical contraindication? Rare. The surgeons never say no, okay? Because they just put things in, and then we have to take care of it. So be careful with that, okay? They do take in account sternotomies. If you have a congenital disease, you need a congenital doctor, and the LVAD, and the size of the LB is important for LVAD. What about ethical situations, right? So we need psychologists to see these patients. We need psychologists to evaluate this patient. And what we do is this. It's a SIPAD score, which basically evaluates the readiness of a transplant or an LVAD. And there's a lot of components. It basically tells you that if you have a lower score, you're a good candidate. If you have a higher score, you're a terrible candidate. But remember, this is a multidisciplinary team. This is not the last decision, but it's important, okay? What about, this is my couple slides, got almost done. What about tobacco and substance abuse? If you're actively smoking, actively drinking, you're not a candidate for transplant. If you have marijuana, this is very controversial right now, especially that marijuana is legal, right? So I don't know how this is gonna end, but we believe that if you do marijuana, you shouldn't get a transplant. This is where I was trained. Minnesota has a different policy. It's something to keep in mind. This will probably change. Last reminder, whenever you don't know what to do, refer to us. But if not, you can go and look for I need help. This is something we can use for this. And just keep in mind the heart failure clinic services. Oh, I'm sorry, did I say failure? Oh my God, it's not failure, it's the Heart Success Clinic Services. I'm sorry. And basically we have a dedicated heart failure nurse staff, there. I always tell people we have appointments set for listening. We have the same room lab, so the lab come into the room, the patient doesn't have to move out. We have our own heart failure pharmacist that I saw Holly, is probably through there. We have our direct phone number for the patient that we see in clinic. We do have our IV diuretic clinics. Yes, IV diuretic clinics, you heard it very well. But only for the patients that we see in the clinic. And then, as you guys know, we have a new bike, which when you have a patient who had unexplained dyspnea, you can send it to us and we can do right heart cath with exercise to kind of find why this patient's having dyspnea and extraction, okay? This is our team, and I think I'm done. I hope I was able to convince you about LVAD and transplants. I don't know if you have any questions. I'm waiting for Alex's question.
I have one.
Go ahead.
So with the HeartMate 3,
Hold on.
with the HeartMate 3, what is the rate of bleeding with that compared to the HeartMate 2?
Yeah, so it's like 0.9%. It's very low. So I can tell you that the amount of bleeding I've seen from the heart, because I was kind of born and raised in both eras, right? HeartMate 2 and HeartMate 3. HeartMate 2 is high, like 2 to 5%. HeartMate 3 is around, it can be 1 up to 2.5%. But we tend to see less bleeding because this pump is a little bit more physiologic. So this patient can have a little bit more pulse. So instead of being continuous, it's a little bit, you can actually feel a pulse. So the risk of bleeding is lower compared to the HeartMate 2.
I gotcha.
John's going to get you. He's running faster than I am.
I'm in a different age category.
Wow, this is going to get deep today.
I'm going to put a hat on or sit down. You talked about the LVAD for the patients, the challenges after 80, but could you give us a little bit more input on the challenges for morbidity with those patients over 80 as far as quality versus quantity and life years for justification for patients and recommending that, yeah, you can get one, but it's a miserable 2 years or whatever it is. Can you get a little bit more in that?
So you asked me about when patients get an LVAD more than 80, right?
Right.
Yeah, so I think the main issue with when you're older or more than 80 is these patients tend to be more frail, will have more renal dysfunction, and that's one of the main limitations for LVAD. You still can put an LVAD in an 80-year-old guy, especially if he's a good 80, right? And there's a chance he can have a good life. But the way I see LVADs is, or either it goes good or either it goes bad. Okay, there's not in between. Because the idea, and I tell this to my patients all the time, I said, I want you to know that you're not alone, and I want you to know that my job is to make your life better. Okay, that's what we focus in the heart failure clinic. Sorry, heart success clinic. So really, it's hard to know. It will be hard to tell you an amount number, but I think someone who's less than 80 has higher probability of having a normal life, for a couple of years, compared that you're older, ending in dialysis, being in ICU for 3 months. But at the end of the day, there's a chance you will never leave the ICU. So I think you have to be a very good 80 so I can say I think you should push for it. So what I will do is try to optimize as much as I can with the medicine, see how we can do it. And again, having a conversation about palliative with these patients, see what else we can do and see their goals, right? Because we always want, as doctors, we want to do what we think is the best, but we need to listen to our patients, right? We need to listen and see what they want. Again, this is not a burden just for them, it's a burden for the family. So it is hard to me, for me to tell you a number or how much it's gonna be, but I can tell you that it's harder. It's harder.
Cheryl's got a question.
So are we talking to the internal medicine doctors who come through the hospital, the hospitalists, for our patients, that a lot of us on our heart failure floor notice that a patient's in heart failure, but they don't consult you guys. They're managing it themselves because they think they can do it.
Welcome to my life every day. So yes, and so you guys know, and I guess not everyone's know, but we officially started our own inpatient heart failure service. So now we round every day in the morning. So we have a dedicated group of our nurse practitioners who will round in the patients that the hospitals will call us. We have a criteria for them to call us to, and at the same time we're working with the PCPs. As you guys, that's something you guys don't know, so you're hearing for the first time now. So I met with the first group of family medicines like 2 or 3 weeks ago, so we can discuss about how they can refer us to us, how we can make this patients better. And the idea of talking to them was to make sure we speak the same language. So because the first things you guys do in general is, oh, my blood pressure of the patient is 90, stop the medicines. Which is that if you stop the medicine, the patient will never get it, okay? So the first thing is you need to assess the patient. If the blood pressure is 90 on those medicines, but the patient is doing fine, not having symptoms, just keep the medicine on, okay? Your first movement should not be to stop him. You should ask the patient how he's feeling. If the patient is feeling well, just continue with the medicine. So we're working on that, towards that, so we can have a better, because believe me, there is a bunch of people that we cannot see, even if we try, right? We're only 2 of us right now working in the clinic, so it's hard. So what we're doing is trying to talk to the PCPs, and we have our next meeting with another group next month, so we can have the same language, and everyone can kind of do the same thing we do. Yes, we're working on it.
I know we find it hard to believe you have enough energy to do any of this. I mean, you're obviously not very energetic.
I still feel that I have a lack of energy, though.
I have a question. In terms of the possibility of minimizing heart transplants and going straight to LVADs, yes, we've seen the technology improve, but we seem to have a lot of the same problems. GI bleeding rates are lower on the current device, but we still end up with angiodysplasias in the colon and whatnot. So do you really think it's feasible that people would end up with LVADs and not need transplants at some point?
I think so. And the reason I presented how much gap we have is because based on data from 2019, if I'm not wrong, I don't remember, it's 2019 data, we only did 3,800 transplants in the country. And I told you we have 62K patients appropriate for LVAD, right? So you're talking that from those 62, only in an average, only 4,000 of them got transplants. So we have 58,000 patients who didn't get anything, right? 4,000 LVAD. So we are very, basically, we don't have hearts just to pick up, So I think so, yeah. That's how eventually will happen, again, when they're able to do it more, an easier way to use it and to have a better quality of life.
And do you want to touch on the different definitions for how we get available hearts? There's newer technology on that.
Yeah, so the way we get hearts, so we have an organization called UNOS, which is the one who will limit our hearts. And people will get hearts versus LVADs depending on how big in the list or how high in the list they are, right? But believe it or not, the lower the number, the sicker you are. The higher the number, the less sicker you are. I don't know why they didn't do it the other way around. And the other thing is, based on CMS and Medicare guidelines, is if we list you for transplant, and that's another reason we got more numbers at LVADs too. If in the next 2 weeks after being listed, if you're sick enough and you haven't get an offer yet, or you haven't get a transplant, then you have to get an LVAD if there's no contraindications. The problem with LVADs now is that LVADs are so good, and we're getting so good at managing them, and people can survive all these years, that before we used to, and the way the allocation system was changed, before if you had an LVAD, you're gonna be prioritized to get a heart. Now, if you had an LVAD, you go from status 2 or status 1, whatever you were at that time, to a status 4. Remember, the higher number, less sicker, right? So people with LVAD now, they're less sick that they're not able to get a heart now anymore, as they used to be before. And that's changing this year. We're not gonna have the data until next year. That's gonna be changing because we're removing the opportunity for the LVAD patient who has been in LVAD for 4 years to get a heart transplant. And again, there's a lot of other caveats, like size, blood type, and other things, right? All the comorbidities that we talk, and I didn't mention all of them because we only have 45 minutes. Other things we take in account, but it depends on that. And I do think the LVAD number will grow up because, again, that's the easiest thing, and then Medicare actually force you to do it, which in a way or another, if you're too sick, you should get an LVAD, right? You shouldn't be in the hospital because it's worse.
And a comment on the brain death requirement to be a donor?
Yes, that's a good thing. I didn't mention that. So, able to increase the amount of organs that we have available in the country, besides a normal organ donor, now we have 3 extra types of donor. One is what we call high-risk donors, which means that are these patients who do IV drugs, who do, they're homeless, and they are high risk because, they can inject themselves, have other diseases that we don't identify during the test. We have hepatitis C donors, which is this patient who had hep C, but now we have treatment, so you can actually get a hep C organ, and then after the transplant, we will treat it and get rid of it. And the last one is, as Alex was mentioning, the way we do the, let me get water. So the way we do the organ donation is, from brain death, right? I'm sorry, I'm not sick. I don't have COVID. It's from brain death, right? But now we have something called, so brain death is DBD, okay? And then we have DCD. So this is death after circulatory arrest. So basically, and it's complicated to explain. Believe me, it's complicated as a fellow to learn this. But basically, these are young people who will die. And what they do is family decided to be organ donors. And what happened is we wait them until we die because there will be organ donors. And it sounds horrible, but that's how it is. We wait until they die. We give 15 minutes of time when the patient goes to a systole or heart rate less than 40. And then after that, we can actually remove the organ.
Yep, and that's increased our available hearts by, I think, 30% or something?
Yeah, like it's like 20%.
Yeah.
But I can tell you it's very complicated because even during my time, so when I started my fellowship, Cleveland Clinic was not doing DCD. And we started doing DCD, I think, 4 months or 5 months after my training. And you actually have to explain patients this. There are patients who by ethic, they say yes, and they're okay with ethics. There are patients who are like, oh no, I'm not doing that. It's very ethical. And I don't want to explain you the process because then you're gonna probably say, I wouldn't use those organs. The process is, there's a lot of ethics involved, but we can do it. That has increased our volume, but still we're gonna be short.
Yeah. I'm glad you explained that because a lot of the people in the room, may or may not have been aware that that's coming or has a pathway by which it can happen. So is there another question?
Is financial capability a determination whether you get an LVAD or a transplant?
Yes, it is. And actually, this is another thing, as Alex has been mentioned about ACC and all these talks we're having, you need to be clear by insurance before you can actually get one of them. And the reason this is important is because you don't want to implant a heart or you don't want to put an LVAD and the patient will not be able to follow up, will not be able to, continue with the medications. And then part of the multidisciplinary team that evaluates if you're a candidate includes financial, social workers, psychologists, heart failure and transplant, CT surgery, and obviously the LVAD nurses, the heart transplant nurses, and it's a big team, and we make a decision based on that. And it is important because the thing is, if you don't have any insurance or you cannot afford care after that, you're actually not doing them a benefit. You're actually doing a harm, yes.
All right, I think that's our last question. A little bit of housekeeping. We had an issue with the web system not giving audio, so we're for those, they probably can't hear me anyway, but I'll say it for everybody else.